Okay, good evening all, and all the participants to this webinar. I am Professor Mauro Tarallo, Professor in Plastic Surgery at the University of Rome La Sapienza. And tonight I have the privilege to introduce and moderate this webinar on the simplified closure rhinoplasty, having as a speaker Dr. Bashar Bizrah. Dr. Bizrah changed the story of the vertical dome division technique, and a story that goes backward to the 30s when surgeon Dr. Satyan originally alluded to this technique. Then Dr. Goldman in 1957 popularized the vertical dome division technique as a method of refining the tip position. But Dr. Bizrah published in 2002 a paper with his personal modification of the technique, modification without delivery of the lateral cruise. And he has performed with this technique over 30,000 rhinoplasty. So he has a tremendous experience about it. And so I'm sure it will be a fantastic webinar, very interesting. And Dr. Bizrah, please go on.
Thank you for registration and thank you for attending this webinar. We start now with the talking about the oblique dome division. This is going to show you how we do septorhinoplasty in a very simplified, straightforward, direct way, endonasally. It will take shorter time and less edema and less swelling after the surgery. The technique is based on, for the tip, on the modification of the Goldman without lateral crust delivery and without marginal incision. Just to give you a brief idea about our textbook, my textbook on rhinoplasty, it was published in 2002 and forwarded by Russell Cradle and Tony Bull and Bernard Coleman from Oxford. It's 500 pages and over 1,000 illustrations. And if you go to this website and this QR, you can see all the book, all the pages, is all free access. And also you can go to our operative videos, over 300 operative videos, second by second, is going by all the maneuvers of septorhinoplasty, special teaching channels for surgeons. This is our next coming webinars in October, November, and December. It's going to be a short ones, only about 30 minutes or 20 minutes webinars. If you have difficulty in watching this through the Zoom, you can go to the YouTube and watch it. Okay. Any question is after the presentation. Okay. What are the factors that affect our result in the Middle Eastern patient? Is the thickness of the investing skin. The thicker skin, as you know, will fail to contract against the newly reshaped cartilage, and also the strength and the control of the alar cartilage. Compared to Caucasian, I mean the non-Caucasian have softer and shorter cartilage, so we need to consider more supportive mean to achieve adequate tip projection and elevation. Also, the wound healing and contraction phase is usually slightly more aggressive than the Caucasian, so it will leave you with more wound contraction, scarring, and fibrosis. The short columella, I mean the tension nose, which most of the noses in the Gulf area and the Mediterranean, they have got the humpy nose with the short columella and the under-projected tip. And also our patients are highly demanding. So it's very important to understand the behavior of the tissue about remodeling, maturation, fibrosis, contraction, and the scarring, because as you know always that there is no perfect healing process. So once we understand that there is no perfect healing process, it means there is no perfect rhinoplasty result, which the patient should understand, and the patient should sign a very informed consent. Our informed consent, about 5 pages, explain to the patient all the possible problem following rhinoplasty and give full explanation to the patient that there is no perfect result, 100% result after rhinoplasty. The skin, you know, all the 6 types of the skin from type 1 to type 6. Therefore, the more you go down the scale, there is more fibroblast, more collagen, more fibrin, and more fibrosis. And this, therefore, no perfect healing result, no perfect rhinoplasty, as we said. In 1999, we developed this new technique, which is based on the Goldman and the I-beam of the medial cura, that we work mainly in the midline. We work in the intermediate crust, and we work on the medial crust. So we work mainly on the midline, intermediate crust, and the medial crust. So we do not work on the lateral crust. We leave the lateral crust alone. So in I started doing rhinoplasty in 1987 until 1999, and watching this, I mean, the results. Most of the problems are really related to the alar side wall due to the external technique or the delivery technique, and then the marginal incision and the exposure of the cartilage. And then, you know, as you understand, the nose is a hollow organ with delicate walls. I mean, the thickness of the nasal walls are very thin. So any mild degree of fibrosis, scarring, is going definitely to show either as notching, as benching, as alar retraction, alar collapse, and even deviation to one side if you have more wound contraction on one side than the other. Therefore, in order to reduce the problem following rhinoplasty, my modification is based on working mainly on the midline and leaving the lateral crust alone, no marginal incision, and no exposure of the lateral crust. So in order to get straight to the technique, the first step of the technique is to identify the tip defining point. Usually since 1999 until the last February, we've been doing almost all our cases under local with sedation. But now after this corona crisis, we're giving GA. So now, I mean, in order to identify the tip defining point, what I mean by the tip defining point is the highest point on the tip. The highest point of the tip is the tip defining point, the highest point of the tip. Therefore, what's matched in when I do this maneuver, this area here is matching the highest point of the tip. This is actually the tip defining point. So I mark this area, as you will see now with the next slide. So this is we match the highest point, and this is the highest point inside. So we are going to work medially in this area. We'll leave that crust alone. No marginal incision, no exposure, no delivery. We will not borrow, we will not steal any part of that crust. So we'll be working mainly on the intermediate cura, as you see, on the intermediate cura only in this area, and leaving that crust alone. No exposure, no marginal incision, no delivery, don't steal, don't borrow any part of that crust. As you will see now, this is a tip defining point, which matches the highest point of the dome in this area. And this is, I'm drawing now the lateral crust, and then the medial cura, and then the junction between the intermediate cura. So therefore, we are going to work mainly on the intermediate cura. You see, this are working mainly on this area, on the intermediate cura. I'm going to work mainly. So this is what I'm going to. I'm not going to go this area. I will not borrow or take any part of the lateral crust. So my main work will be on the intermediate cura, and this is a point matching the tip defining point on the alar rim in order to mark from inside the tip defining point. I mean the junction between the intermediate and the medial cura. As you will see, this is now the junction between the intermediate and the lateral crust. So the lateral crust is left alone, no marginal incision and no exposure. So this is matching the highest point of the tip. The lateral crust is left alone. Now the first step of the procedure. Second step is to obtain a septal graft. Remember, we are working endonasally. So we make an incision. If we are going to do tongue in groove technique, I make the incision only 1 millimeter or 2 millimeter behind the caudal margin. If I'm not going to do tongue in groove technique, I will do the incision about 1 centimeter behind the caudal margin, and then I will obtain the septal graft. As you see now, this is going second by second because I went straight to the right plane, no much bleeding, as you see. You see there's not much bleeding at all. And can you see the cartilage in white color? Already elevated the left perichondral flap in a few seconds. And then now, again, going to the right plane and elevating the right perichondral flap, as you see. So the right perichondral flap, again, elevated in a few seconds because we are on the right plane, exactly on the right plane. No bleeding. You see, when you work on the right plane, you make your life easy and everything will run very smoothly. I divide the cartilage 1.5 centimeter below the dorsum septum and then obtain the septal graft in order to use it as either a columellar strut or a tip graft. Now the third step is the intercartilage incision, which is made at the junction between the mucosa and the skin, and always near the midline, only 1 centimeter from the midline. So stay medial, do not go lateral. Do not borrow or steal any part of stay medially. So this is the midline there, and I'm only 1 centimeter away from a midline, and I make the incision at the midline. I see just 1 centimeter, or if even less than 1 centimeter away from the midline. So no need to go lateral. Try to stay near the midline and preserve the structure. So this technique is mainly really an incisional technique more than an excisional technique. As you see now, we are just now undermining, and we are exactly at the midline working. And next step now is to reduce some of the supraalar fullness. So we trim portion of the lateral cura, portion of the apparatus, the curvature of the apparatus cartilage with small scroll from the lateral cross. So we reduce slightly the supraalar fullness, and this is, you will see, this is the only part which is going to be excised during the procedure. So this is the portion, the part of the curvature of the apparatus cross and small of the skull, lateral cross skull. You see, this is small portion excites from there, and we do the same on the other side. You see very small incision near the midline, preserve the mucosa, keep the mucosa down, and excise this small portion from the curvature of the apparatus cross and the skull of the lateral cross. Now, okay, and now this is the most important step of the procedure, is to divide the intermediate cura obliquely from the medial crust and to preserve the limb cartilage. So what's going to happen now? We are going to now divide the dome. How will we divide the dome? First of all, we will not do any marginal incision. We will not expose the lateral crust. And this is the you see medial cura, intermediate cura, and the lateral crust. So our main work is going to be on the intermediate cura, and we are going to divide the intermediate cura from medial to lateral, So when we do that, when we divide the intermediate cura from medial to lateral, the intermediate cura will be two portions. This portion, the lower portion, is going to be in contact with the lateral crust and form the limb cartilage. So to preserving the limb cartilage and preventing notching. And this portion of the intermediate cura is going to augment the medial cura and give you more tip projection and tip elevation. Therefore, the intermediate cura is going to be two portions. The upper portion is going to augment the medial cura, and the lower portion will stay in continuity with the lateral crust and preserve the limb cartilage. So how we divide the dome obliquely from medial to lateral, preserving the limb cartilage, and this is the portion of the intermediate cura that's going to augment the medial cura. And this is the limb cartilage is preserved in order to avoid any notching in this area. I think this is quite clear. So this is how we divide the intermediate cura divided. So portion stay with the lateral crust to preserve the limb cartilage, and this portion here, this portion is going to augment the medial cura and give us more tip projection. And you see now, this is our intermediate crust, very clearly, and we are going to divide from medial to lateral. So we'll be working mainly on the intermediate crust. We are not going to borrow, we are not going to steal any part from the lateral crust. So that we are going to work mainly on the intermediate crust and divide from medial to lateral. So we have two portions of the intermediate cura. Upper portion is going to augment the medial cura, and the lower portion is going to preserve as the limb cartilage, and will stay in full continuity with the lateral cross, as you see now. So this is, I mean, how this motion here is going to augment the medial cura and give you more tip projection. I see now with sharp level hook now, we hold the medial cura. So you hold the medial cura, you don't hold the lateral cross. So when you hold the medial cura, you are looking directly onto the intermediate cross. You see, when you hold the medial cura with the sharp level hook, and then divide from medial to lateral, as you see, reserving the rim cartilage. And this now horizontal portion of the intermediate cura going to augment the medial cura and give you more tip projection. So this portion now will augment the medial cura. Again, we do the same on the other side. As you see now, we just mark the tip defining point. This is the tip defining point, junction between intermediate and lateral cross, and will divide obliquely, preserving the rim cartilage. So two portion, upper bone, the lower bone, the caudal portion will stay as the rim cartilage, as the cephalic portion. This cephalic portion of the intermediate cross is going to augment the medial cura and give you more tip projection and more tip elevation. So now we deliver both the intermediate cura and the upper portion of the medial cura. So we're going to deliver the posterior divided portion of the intermediate cura. So this is the cephalic portion of the intermediate cura, which has been delivered and added to the medial cura. It's added to the medial cura, so it gives you more tip projection. Again, this is the portion of the intermediate cura, which is going to be added to the medial cura and give you more tip projection. As you will see now, using the right instrument, using the fully curved blunt scissor, you can deliver both intermediate cura and the upper portion of the medial cura in very short time. You see, few seconds, and you see now this is the intermediate cura and the portion of the medial cura, and we'll now just remove this interdermal connective tissue, as you see. So we are looking now at the intermediate cura. This is the intermediate cura, and this is the medial cura. So this portion of the intermediate cura is going to augment the medial cura and give us more tip projection and more tip elevation and contribute for tip rotation and refinement and symmetry, as you see. Now, the next step is to, as we said, in our patient, we need to make a supportive mean. So the skin is thicker, so the skin is heavier, the cartilage are softer, the columella is short in most patients. So we have to consider a columella strut and a tip graft in order to achieve more tip projection and more tip rotation. So we shape the septal graft into a columella strut and into a tip graft. And if you don't have septum, for example, in revision cases, you go to and get a concave graft. And as you see now, this columella strut will go into pocket between the two medial cura, to this pocket into between the two medial cura. It will augment the medial cura as the intermediate cura. And you see with sharp scissors, we make a small pocket down, just slightly above the nasal spine, down all the way through, as you see, and then we will get the columella strut, insert the columella strut, and we suture this now three structures together: the conjoined intermediate cura to medial cura with the columella strut. So the conjoined intermediate to medial cura with the columella strut are sutured together. So this is now a very important maneuver because it will treat for you the columellar problems and also improve tip projection, elevation, and symmetry. So this maneuver will treat any short columella, any hanging columella, any retracted columella. Very important maneuver. As you see now, so it's like sandwich effect, and we keep our portion slightly open there to give more natural looking and make it as a bed now for the tip graft. So, and actually in almost most cases, I use a tip graft in order to get more tip elevation and more tip symmetry. So again, with sharp scissor, we make a pocket along the caudal ends of the medial locura down, and then we will insert the get the tip graft, insert the tip graft, and then suture this structure, all this structure together. So we now have a very strong foundation, always like long tip graft, because I want to augment this nasolabial angle. I want to augment the nasolabial angle, like to augment the nasolabial angle. So always I like to have a long tip graft. So when you augment this nasolabial angle, it will open this angle for you, give you more natural looking, and it will give you more rotation of the tip. So this, as you see now, a longer graft will augment the nasolabial angle, and you will achieving a very strong foundation on the midline of conjoined intermediate to medial locura, supported by columnar strut and tip graft, as you see. So we have a very strong foundation, very strong structure in the midline. It's conjoined intermediate to medial locura, supported by columnar strut and tip graft, and this will give you will help you in achieving and obtaining more tip projection, more tip elevation, more tip symmetry, and more tip rotation, and treating the short columella, the hanging columella, and the retracted columella. And you see now how much stretch of the columella we achieved. Very nice columella, very nice symmetry. Look at the symmetry we achieved with this nice technique, and more tip definition, more tip refinement compared to the patient. If you look at the patient photograph before, also we're still in an early stage of the procedure. There are another many now additional procedures we're going to consider in order to achieve more tip definition and more tip refinement. And actually most of our patients, they require and they need sharp tip definition. So in this technique, you should be prepared to work very accurate and very symmetrical manner. Now, what's the additional procedure we need to do in association with the modified dome division in order to achieve more tip projection and more tip definition? We'll start with the lateral technique, then we talk about the spanning suture, the percus approximating suture. This technique will give you more tip definition. Actually, most of our patients, they always ask for a smaller tip. They want a very defined tip. They want more feature looking nose. And then in order also to achieve more tip projection and more tip elevation and rotation, we'll go for the tongue in the groove technique. And we are going to do all this technique endonasally. And then I call something called the tip lift at the end. In order to preserve the already achieved tip projection and definition, we need to divide the bristles septi muscle to prevent the tip of drooping down later after a few months, because if you don't divide this muscle, the tip will be under continuous tension from this muscle, and it will go into pull the tip down for you later. Therefore, it's also mandatory procedure in some cases of tension nose, patients who say the nose drop down when they laugh or smile or when they talk. So in the lateral overlay technique, I mean, we will be visualizing the lateral crus, and I will see how we divide the lateral crus in the midline endonasally. You will see how we do it endonasally now. You don't have to do the external approach, and you don't have to do the delivery approach to do that. So and after we have done the oblique dome division, and you're just looking at the lateral crus, and we just mark the mid portion of the lateral crus, as you see, and then with sharp scissors, we go under the skin with sharp scissors, and we open the scissors for about just less than 1 centimeter, as you will see now in the video, and then divide the cartilage. You see now, after you divide the cartilage, and then once you divide the cartilage, what will happen? It will fold together. After folding, you make your lock and suture to secure this overlay of the cartilage. So this is the lock and suture to secure the overlay of the cartilage. And you will see now the same patient before, after the oblique dome division, but still the patient requires more tip definition and more tip refinement. And you see the lateral crus are still bulging. So we will not go and trim any portion of the kyphic lateral crus. We go and visualize the lateral crus. I will see now. We go and we see looking at the midline there. You see the midline there. And now we make this our marking, as you see. And then with sharp scissors, we get sharp scissors. And we go slowly under the skin, as you see, under the skin, slowly. and open for about, you scissor for about just 1 centimeter or less, slowly. You see, it's very nice, extremely nice technique. You don't have to make external approach. You don't have to make, the delivery approach. This technique, you can finish all the tip in about 20 minutes. The oblique dome division, the Nuestra, the tibia graft, the lateral overhead technique, and the other maneuvers. Then you turn your scissor 90 degree and divide the lateral cast, and so the both portion are overlapping each other, and this way you're reducing the supraalar fullness. You are very nicely reducing the supraalar fullness. And we do the same on the other side. You see, compare between both sides, how the supraalar fullness has disappeared from the left side, and we do the same on the right side. You see, our technique will preserve the lateral cast, no marginal incision, no exposure, we not borrow or steal any about the lateral cast. The lateral cast is kept very secure, flap in a place, and then again we'll go under the skin, gently, slowly, as you see, and then turn the scissor 90 degree, divide, and get it to overlap. Now you may do secure lock-in suture. You may not do lock-in suture. Usually I do lock-in suture, but in this case, because I'm doing now a spanning suture later, there is no need to do the lock-in suture because the spanning suture is going to act as a lock-in suture and lateral cast approximating suture in next step. So now you see you achieve more tip narrowing and more tip refinement and definition, but it's still not enough. It's still not enough. The patient has got what you call the thicker skin, so still not enough. We need to do more technique, to give more tip definition and more tip refinements. Another slide to show how we do the securing suture in both sides. Now the lateral cast approximating suture, the spanning suture, we are going to achieve more tip definition and more tip narrowing and more tip refinement by doing this technique. And this is how the suture will go. It will go through the intercardiac incision just behind the superior septal angle and going all the way through and making a small bite of the lateral cast, going back, making another small bite and making the suture. And you will see now by the video more clearly. You see now the same patient before. We had oblique dome division and he had lateral overhead technique indonesially. Now on the same patient, I'm doing spanning suture. So the suture, you go to intercardiac incision and just behind the superior septal angle, 1 millimeter behind, you go through and through as you see. And then we go to where we did our lateral cast overhead technique. We just make the suture through. So this suture is going to act as a lock-in suture and act as a lateral cast approximating suture. You can see the effect of suture now, how it is reducing very nicely the supraalar fullness in this area. So this is the effect of suture. And in the same time, the beauty about it, you did not excise or remove any portion of the kyphic lateral cast or the procedure. So we are actually preserving the structure. It's an incisional technique more than excisional technique. It's a reshaping technique and rearrangement technique more than an excisional technique. You see now, I'm going again through the lateral overhead technique side, you see, and this will act again as a lock-in suture and as the spanning suture. You have to work accurately and symmetrical way when you're doing this maneuver. If you are not prepared to it and accurate and symmetrical way, do not try this, or even do not try even rhinoplasty at all. We're going back again through the intercardiac incision from one side to another in order to achieve more equal tension on both sides before we do the knot. You can do the knot straight away, but I would prefer to go through and through again in order to achieve more equal tension on both sides, so I achieve more symmetry, as you will see now. You see now how this suture is reducing the supraalar fullness slightly. And the art of this suture, that when you do this suture, don't squeeze, just approximate, don't squeeze, never squeeze. You want only to approximate the lateral cast towards the midline and get closer to your intercardiac incision. So do not squeeze the suture. And you will see now the big difference between before and after with preservation of the lateral cast. So the lateral cast, we did not steal any part, we did not borrow any part, and we did not trim kyphic lateral cast. You see now, very nice tip definition, very nice tip refinement, very nice symmetry with this technique. Look, very nice symmetry. So, and you see now with the next video, you see the nice symmetry, the strong alar sideward, the very strong alar sideward, because the lateral crest is there, no marginal incision, and you see the big difference now, almost half size of the tip. If you compare between before and after, almost half size. You see now the big difference, the nice tip definition, the nice tip refinement, the nice tip another one. It's actually a magic technique. It's straightforward, quick, no need to do external approach, no need to do marginal incision. So it is the same patient again. Look at the side view, look at very nice profile we achieved with this patient. Nice nasolabial angle, nice double break, nice supratip break, very nice symmetry of the tip, very nice symmetry of the nostril. Please tell me which technique will give you such symmetry of the nostril. Let us be honest with ourselves. Which technique is going to give us such symmetry with the nostrils? Well, because we preserve the lateral crest, we will be working in a symmetrical and accurate and equal manner. So it's very nice, extremely nice, as you see, nice results on table. Now, if you have not done the lateral crest overlay technique, we still do the spanning structure in some cases. If there is no bulging of the lateral crest, but still the tip is wide, as you see, for example, in this situation, I'm not going to repeat the whole procedure. You only make a bite after going through the anterior septal angle and the intercardiac incision. You only make a bite, small bite on the lateral crest, and you see the effect of the suture, and continue the suture as before, as the previous video. But in this patient, we did not do the lateral crest overlay technique. We only went straight to do the spanning suture by making a small bite as the cephalic lateral crest and going through and through again, and doing the same on the other side, and then making the knot. This is the same patient. You see the same patient. You see what was before and after. You see now, you see the big difference between before and after. And I want you to watch the symmetry achieved by this technique. Look at the very wide tip, wide, obtuse, ill-defined tip, and you should see the result after. Now, if you have any problem watching, you can go again to YouTube. Use the QR. You can take photograph and go to the YouTube. Now, the Indonesian tongue in the groove technique. Again, you don't have to do the tongue in the groove technique through an external approach. We can do it Indonesially and do our septocolomellar suture this way, as you see. In this way, when you do your septocolomellar suture this way, starting from here, and then going through the medial cura from medial from inside out, and then back, and then going from inside again out. This will make the two medial cura to overlap the caudal septum, and you get your effect of the tongue in the groove technique. I mean, the aim of the tongue in the groove technique is to take this two medial cura to overlap the caudal septum, and for the caudal septum to go into this pocket between the two medial cura, as you will see now with the coming video. So this now we're preparing the caudal septum from the other side, because we did the septoplasty. So from the left side, I'm trying to expose small portion of the caudal septum from the right side. So prepare this portion to go inside between the two medial cura, into a pocket between the two medial cura. Prepare this portion. And then this is after I have done the oblique dome division and the colomellar and tibia graft. I make it against the pocket posteriorly, preparing for the caudal septum to go into this pocket, as you see now. And then both the pocket and then again with fully curved scissors, make sure that the pocket is adequate between the two medial cura, adequate to accommodate the caudal septum. So using the right instrument in the right place will help you and make your life easier. So as we will start our septocolomellar suture, and this is the aim of the suture, is to get the two medial cura to go in between the two medial crura to go around the caudal septum. So we start high up on the septum, through the cartilage and through the perichondral flap, and then from in and out on the medial crura, as you see, from in and out medial crura flap, in and out, and then back to the septum and the perichondral flap, through and through. Yes, you see, goes through the flap and the cartilage, as you see. And again, on the medial crura flap on the left side, from inside out, medial crura flap, from inside out, high up, halfway on the medial crura flap, halfway. And then now make your note, and with your finger, make sure that the caudal septum now is going in between, the caudal septum is going now in between, in this area, in between here. I mean, in between the two medial crura. With your finger, adjust the caudal septum to go in between the two medial crura, and then make your knot. And this way, the two medial crura are going around the caudal septum, achieving your tongue in a groove technique. This tongue groove technique will give you more tip rotation. Very important, will give you more tip projection also. So it's very important in the tension noses, in the long noses, in the droopy nose tips. Very important to consider this tongue in a groove technique to give you more open nasolabial angle, and treat for you the tension nose, the long nose, short columella, the acute nasolabial angle. So to give you more tip projection and more tip elevation. We do another suture also, and just to be for security. So make two suture, one up, one slightly below. Again, through, and then through the medial crura flap from inside out. And then we go back again and do the same on the other side, through, and then through the medial crura flap from inside out. And this again will get the two medial crura around the caudal septum and achieve your goals, as you see. So going back again from inside out through the medial crura flap. This is very clean procedure, very nice, less invasive, no much exposure. You have to reduce exposure because, I mean, the more exposure, the more fibrosis, the more scarring, the more wound contraction, the more problem like pinching, notching, retraction, deviation, asymmetry. So this is really a very nice technique trying to minimize the procedure and more conservative. So again, will be less edema and less swelling and less mobility and early return back to work. You see, a very nice nasolabial angle, very nice double break, nice suprated break. You know, this is now operative result. The tip will definitely going to drop down by at least 2 millimeters in the next few weeks after surgery. So you see, very nice result we achieved with such techniques. Now, what I mean by tip lift? I mean by tip lift is to divide the bristles septine muscle. After doing the tongue in a groove technique or doing your tip blasty, you need to preserve this tip projection and elevation. If you do not preserve this tip projection and elevation, the tip will drop down again. The tip will drop down again because the bristle septine muscle and the alar nasalis, the bristle muscle here, both this muscle will be acting all the time on the tip. So during the next few months after surgery, the tip will be under continuous tension down from these muscles, from this muscle and from this muscle. So therefore, the tip will drop down. That's why many patients tell you my tip was very nice first few months. After 6 months or after 1 year, what happens? That my nose dropped down again because we did not divide the bristle septine muscle and we kept the tip under continuous tension from those muscles. If you look at this patient now, when he smiles, when he tries to talk, how his tip is dropping down. It's typical tension nose with hump, very short columella, under projected tip, acute nasolabial angle, and she's the effect of the bristle septine muscle on this patient. Let us go to another video, it's more clear. So we see how we are going to divide this muscle now. So I'm just showing and illustrating the muscles before I'm doing the division. And we need to divide this muscle from the nasal spine, as you will see now. You will see now. And I tell you why I call it nose lift. You will see why I call it nose lift, because I make a special suture at the end, which is going to elevate and pull up the structure of the nose in order to keep to prevent the muscle and regrowing again to the nose. So we'll cut the foramen first, as you see, and then with going to the nasal spine, and then with fully curved, and you make it like you are doing like suturing machine, tick, 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 tick inside. You cutting the muscle again, tick, tick, tick on the left side. You are just cutting the muscle, and then removing the muscle from the nasal spine. Very important step is to scratch the muscle away from the nasal spine. So we are now cutting both the dorsal septi muscle and the iliac nasalis muscles. And then with Briston elevator, we're scratching the muscle away. Make sure that the muscle is scratched from the premaxillary area and from the nasal spine. Very important from the nasal spine to scratch this muscle away, so it will not go again. Because if you don't do that, it may go against the muscle. So you see what I'm going to do now to reduce as much as possible the muscle going down. I get the suture down from one side, and then I take it to the other side. And in this way, you will see now I'm going to put the nose up. So that will prevent the muscle of going again to its original place. And what will happen, a connective tissue will form. Connective tissue will form in this area. And this connective tissue will have no function, and it will not pull the nose again down. So you see now the effect of this suture. You see the effect of this suture now on the upper lip. That's how it's pulling the upper lip up. So the upper lip, and so the whole nose being pulled up now. So the muscle will reducing the chances of the muscle to regrow again to the nasal structure, as you see now. So we're getting, and this will give you more tip rotation, this maneuver, and we'll do the same on the other side. We'll do the same on the other side, as you see now. Okay, do the same on the other side. So this is, I call it tip lift, because I do this suture, and this suture will lift up the whole nasal structure for me. Okay, sorry, it's just going now. And you see the effect of this suture. You see now the very nice result, how this nasolabial angle being opened nicely, very nice tip projection, nice double break, nice supra tip break. So this will give you more tip projection and more tip elevation and more tip rotation. Now the air language resection, sorry, I have to go back, sorry. Yeah. Again, air language resection. Now go back. Sorry about this, go back. Next. Okay, language section now. So many we stay within the fold. As you see, we don't go lateral to this point. Never go lateral to this point, because you stay inside the fold. If you stay inside the fold, you will not get a scar. So don't go out to this area. Don't go up to this area, please. So stay inside the fold and use your finger. I use my finger to form this angle. It's very I've been doing this way for the last 20 years. And I put so many videos. You see how I push my fingers there and create this angle. You see, very nice way, create this angle, and then connect from lateral to medial. And you will see now we achieve very equal result. It's not, this is a marking of my face suture. It's not important how you leave. What's important is what you leave behind. Not important how much you excise. What you leave behind. And you see now the symmetry of the nice symmetry of Nuestra before air language resection, the beauty of our technique, the oblique dome division. So the patient already had oblique dome division, and now we are doing the air language resection. And of course the finger one. I was surprised when I looking at the program of Dr. Father, if somebody had put the air language resection, the finger. So actually it's my technique, which I'm the one who actually been doing this technique for the last 15 years on my videos. If anybody wants to show anything, that's fine, but please refer to me, make reference to me. Thank you. So we start the first suture through and through, as you see, through and through, the first suture, and then So we put marking for the first suture, will make your life easy when you put marking for the first suture. And you see now it's coming edge to edge, exactly edge to edge, coming very nicely there, edge to edge. So stay inside the fold, don't go so much lateral, because if you go lateral, you will patient scar. In this way, the patient will not see scar after 6 weeks. We'll make another suture at the end. You see? And sometimes I do subcuticular, sometimes I got interrupted, and sometimes I put to glue also. So it depends on what available or was the case. So it's very nicely done, as you see, very nicely done. The main thing is your approximation edge to edge, as you see, and we stay medial also, don't go lateral. The main thing that you do not go lateral. When small, always keep a small bite, stay near the edge, again to avoid scarring. You can see a lot of my videos, so many cases for iliac wedge resection, and using this finger technique in order to achieve more equal and more symmetrical nostrils. And we'll be doing the same on the other side. And you see the difference between before and after. You see the nice symmetry. This is the beauty of this technique, the symmetry which is left behind, the nice tip definition, refinement, narrowing, and the symmetrical nostril, the stretched, nicely stretched columella, the strong support and foundation in the midline, as you see now. Quite nice, and obvious results. Now, the arts of osteotomy, how I do my osteotomy. So really today, how I do with the rhinoplasty. I'm doing this technique in almost all my cases. The same like Tony Bull was doing this technique for all his all of his cases, sorry. But you know, Tony Bull and the others, they were delivering the lateral cuss and then dividing the lateral cuss, which left the iliac side wall with very weak and secure flap. For my modification, I leave the lateral cuss alone, no marginal incision, no delivery, no exposure. And we do not steal or borrow any part of the lateral cuss. The art of osteotomies, I do it always the Tony Bull technique, the external approach, as you are pressing on the egg. So when you do it, you can better control because you are going through the periosteum and the bone, but not going through the endosteum. Very important to leave this portion of bone intact here, the blue one intact. So very important. So you start high up with the lateral osteotomy, and then you go slightly down, start high up. So preserve this portion, the blue one of the bone, and then go back again through the line up the line. So we're doing the mid lateral and we're doing the lateral. Again, we're doing on the same side, exactly as a pressing on the egg, And you see now, I always keep my osteotome vertical, not horizontal. So when I keep it vertical, I keep a small portion of the bones intact. Very important to keep your osteotome vertical, not horizontal. So keep it as you see vertical and preserve this portion of bone and start high up and then go down and then go up again, going through the periosteum, the bone, but not going through the endosteum. So do not go through the endosteum. So exactly as when you press on the egg, you keep the inside membrane of the egg intact. So you're doing the same. So this will prevent collapse of bone after the osteotomy. So this is, you see now the full mobilization of the nasal bone, right and left, without any collapse, because we did very gentle osteotomy and we preserve the endosteum of the inside membrane of the bone, as you see now. Okay, I'm just putting some push down on the hump. Okay, so it's very nice. This is the art of osteotomy, how of doing full control of the osteotomy. We'll see more now when doing the hump push down technique and osteotomy. For example, with this case, as you see, patient has got a wide tip, and she has got wide, obtuse, ill-defined tip, and got moderate hump. Mild to moderate hump, you may go get away with the push down technique. Larger hump, you need to do the hump excision. Now, this patient at the end of the procedure, she had tibplasty, oblique dome division. She had iliac wedge resection, and she had spanning suture, And this is the hump. You see now the hump is much less now because we achieved adequate tip projection. So this reduced the size of the hump. It's what's now is when we did obtained the septal graft, or we did the septoplasty. This is the nasal bone. This is the upper portion of this is the dorsum of the nose, and then this is down this is the iliac crest. The maxillary crest, and then we went about 1 centimeter behind the caudal septum. 1 centimeter behind the caudal septum, about 1.5 centimeter below the dorsum septum, and we empty this area. We remove the cartilage and we also remove the bone. So you have to empty this area because you need to allow space for the bone to drop down. If you don't empty this area, so you get deviation and you get resistance. So you need to empty this area down above the maxillary crest, get your septal graft, and remove portion of the vomer, move the bone, so you give space for the dorsum to drop down. You make empty space for the dorsum to drop down. So this push down technique is very nice because when you do exercise the hump, you always end, or most of the time, with roughness on the dorsum or irregularity of the dorsum because of the scars and fibrosis. So now with the push down technique, we have done this septoplasty, and now we will do the mid-lateral osteotomy, again, vertical as you see, vertical, don't go lateral, vertical all the way through, and again, going through the periosteum, the bone, but not through the endosteum. Again, going high up and then going low down. Start high and go down and then high up again. So preserve the small portion of the bone below to avoid collapse of the ala. Again, we do the same on the other side, mid-lateral, hold your osteotome vertical. So when you hold your osteotome vertical, you're not cutting through the whole bone. You keep a small portion of the bone intact and going through the periosteum, the bone, but not through the endosteum. Again, start the lateral osteotomy high up and then go slightly down as explained, and then high up again, exactly as pushing on the egg and keeping the inside membrane of the bone intact. And you see now full mobility, right and left, right and left. You see now, and then push the hump down. Push the hump down with your finger. You see, push the hump is pushed down. And this will give you a very nice, almost natural result. Very nice, almost natural result. Okay, now how we do our dressing. So I'm taking you through the procedure completely, how I do it myself. You see the very nice, extremely nice result. The osteotomy site, the adequate resection, the tip definition, the tip refinement, the tip narrowing, the symmetry we achieved, and we did the hump push down. And now how this patient with pre-op photograph, mild hump, deviated nose. This is another patient, deviated nose, wide tip, wide alar base. She had full septorinoplasty, correction of the deviated nose, achieve adequate tip projection, tube innervation, hump reduction. So we move now the eye cover, and then we start our dressing. I don't put the strips straight into the nose, the skin, because some patients may develop allergy to the strips and sometimes may end with some ulceration. So I make this sponge on the dorsum first, and then with 3 strips, I start put under some pressure. You see, push it down. So it's a very nice way of doing the dressing. You see how, because the patient had got, you've seen the photograph. I want to show you this case because the patient had got deviated nose. So we did osteotomy, and the nose now is exactly in the midline. We make this goes. We want to cut the dead space. We want to cut the dead space between the blaster and the nose. So because if you keep any dead space, then your nasal bone may lateralize. So it's very important to use this gauze. And now again, we are putting pressure on the push down, on the hump which being pushed down. This will keep the hump down for the next 1 week or so. So it's very important to do this. That's why I want to show you how I do my dressing, how I do it. I try to cut any dead spaces between the cast and the nasal bones. So keep the nasal bones under firm pressure, and this will give you the best results all the way through. I use two splint. First, I start with thermal and hold it, and I count to 60 or 70. And then after I count to 60 and 70, I will start to remove the cover of the, and put, keep pressure. So keep it tight. You want to cut any dead spaces between the bone and the splint, and this will keep your nose straight. So the bone will not lateralize to right or left. Once you support the nasal bone and the dorsum with the sponge, and the side of the nose with the gauze on top of the steri strips. Again, double, and put your, I always put it the opposite way around because I want to keep this one here pressing on the nasal bone. There is no point to put it the other way around. You want to press on the nasal bone, your osteotomy line. So this is the correct way to do it, that you press on your osteotomy line. This is the way how to put your splint, not the opposite way around. Okay. Now, conclusion, you are about to finish. Thank you for being with me. Thank you for to be patient. I hope you find it enjoyable and you find it something new, something interesting. So it's a time-tested, trainable technique. It's direct way of reducing the droopiness and widening of the nose by considering that a co-overlay technique and the tongue-ended groove technique, and recommended in all tension noses. Actually, I do this technique for all my rhinoplasty.
Sta facendo le conclusioni lui.
Guarda che bella, mammina.
So, again, you may go to YouTube and again, you may go to YouTube and this QR if you want to watch it on YouTube.
Ok.
No, I haven't finished yet. Wait. Wait. Yeah. Now this summarizing the technique, summarizing the tip technique, not the rhinoplasty, tip technique, simplification of the tip defining point, and then the oblique dome division, tip defining point.
Accendo il microfono, Stefi?
Sì, sì.
Quindi si sente adesso quello che...
So this is the tip junction between intermediate and lateral crus, and then the oblique dome division, preservation of the rim cartilage, and this is the cephalic portion of the intermediate crura, going to augment the medial crura. So the dead body of the intermediate and medial crura, and considering columellar strut and tip graft, as you see. So this is on table results, as you see. I have seen the cases before, and you see how much in one patient, much we achieve result. This is about 18 months following surgery. You see the big difference and how we can deal nicely with these large, very wide noses with thicker skin, and you see the symmetry achieved by this technique and the tip definition and refinement achieved by this technique. So this technique really is, you can use it in all cases. It will correct for you under projection, it will correct over projection, it will correct the short columella, the hanging columella, retracted columella, and correct the supraolar fullness, and it will really good assessment of the, because endonasal, good assessment of the dorsum to the tip all over the procedure, and it's very useful in revision cases. It will save you extensive undermining and exposure. So you go straight to your goals when you're doing the revision cases. Also, it's less post-operative problem, less post-operative edema, more natural looking noses, and because we preserve the structure, we preserve the lateral crus. Once you preserve the lateral crus, you would not borrow or change its shape, you will get more natural looking patient, and more patient satisfaction, because less edema, less swelling, early mobility, and also less medical legal complaints. And the key maneuver, and I've seen the key maneuver for successful procedure, that you add to the oblique dome division the tongue in the groove technique when indicated, the taco-overlay technique when indicated, the spine suture when indicated. I want to show you this patient with deviated nose. You see deviated nose to the right. So he had multiple osteotomies, he had tibuloplasty. This is only 10 days post-op. You see a very little edema, only 10 days post-op, with patient who had multiple osteotomies and had full tibuloplasty. You see the same, the side view of this patient, only 10 days post-op, and the base view of this patient. Now, just some photograph about our before and after. I'll go quickly. before and after. And actually, you can go now to our videos. You see more than our Rhinoplasty, Bizrah Academy. You see more than 300 operative techniques, more than 300 operative techniques. Second by second, we did not cut any portion of the procedure. And you see how we do septorhinoplasty in sometime in 20 minutes, sometime in 30 minutes, maximum in 40 or 45 minutes. When we use rib graft, we may reach an hour. If we use an autograft, you see the tip definition refinement we're achieving with these techniques. Again, another case of deviated nose, and you see now also the side view. We achieve more tip projection, more tip elevation. We treated the hanging columella, and we treated the hump. And again, the same patient, the base view more straight, more defined, more tip definition refinement and narrowing. Again, very, this case I have done maybe 25 years ago. This patient, very old patient of mine, see the side view. And also the base view, I lost actually the color. This is a black and white photograph from my textbook. Again, another case of deviated nose, hump, and you see the side view, how much tip projection, elevation, definition, refinement we achieve with these cases. And treated the bifid columella. Is the bifid columella being treated and the deviated columella being treated. Another cases. I'm going to move quickly because I'm sure you are now tired. You see how much definition we achieved. We're dealing with difficult cases, very thick skin, as you see, nice tip projection, hump reduction, nice tip projection, and you see the base view will give you the main advantage of this procedure and the result, the symmetry and the narrowing and the definition of the nose with this base view. Again, it's very useful in Chinese and African, extremely useful technique, and the oblique dome division, my modification is very useful in Chinese and African. You see this patient, I did rib graft, augmentation rhinoplasty with blepharoplasty. I did also the Asian blepharoplasty. So she had full tip plasty, she had rib graft, and you see the big difference between before and after for her nose and for her eyes. The side view of the same patient and the base view of the same patient. Also in African patients, see how much patient got tip definition, how much tip definition we achieved with this technique, oblique dome division. And the side view, again, she had rib graft, and you see the narrowing and definition we achieved with this technique. It's very nice result for this patient with thicker skin. You see, we deal with patients with difficult skin, very thick skin, and you see how much definition and narrowing we achieved. And mainly, if you look on the base view, you see the big difference on the base view. Again, deviated nose and wide asymmetrical tip, very straight symmetrical nose. The side view much better, more tip projection, more tip elevation, and you see in the base view the nose was deviated to the right. It's more central, more tip narrowing, more tip symmetry. Again, very deviated nose, and you see the big difference between before and after, and the tip become more symmetrical. And you see from the base view, give you the best, as you can see, the best result from the base view. Again, similar cases, so I want to finish it now. Okay, this is our textbook, and it's available. If you go to this QR and you get to the free to the textbook, 500 pages, 1,000 illustration, and to our over 300 operative video, you can go for it second by second. And this is for YouTube, your QR. And this is our coming, if you want to take photograph of this, our coming now webinar next month, and will be with me, the moderator, Professor Fawzi Hamza from Egypt, the president of the Egyptian Plastic Surgery Society, and Professor Atif Ahmed also will be going to be with me with the next webinar. And this is the time of the webinar, the same time actually as today. Thank you very much for watching. For any clear question, please go to this email. I'm waiting for your question. You are most welcome. Thank you for attending. Thank you for watching. I hope you find it useful, and I hope you take with you a good message tonight with this nice presentation. Thank you very much.
Thank you, Dr. Bizrah. It was absolutely clear and very brilliant. I've actually a few questions for you. And why do you believe that the dome division technique is more superior than the other techniques?
First of all, as I explained, actually, there is less exposure and less surgery. You are mainly working in the midline. So actually, you are mainly working on the intermediate cross. So the lateral cross is, as you have seen, is left alone. We did not borrow, we did not steal any part of the lateral cross. No marginal incision, no exposure. So actually, actually, you're reducing the wound healing, contracture, scarring, and fibrosis on the alar side wall. And this is, I mean, with my experience, I started doing rhinoplasty in 1987. And from 1987 to 1999, I was doing mainly the external approach. And we met with so much problem of wound contracture, scarring, fibrosis, notching, benching, alar retraction, and even deviation. Sometimes if you get more wound contraction and scarring in one side than the other, it will put the tip to the affected side. So there's a lot of problem, especially in the darker skin patient. Because the darker skin patient, there is more fibroblast, more fibrin formation. So there is for more wound contraction and scarring. With this technique, you can achieve all your goals instead of spending sometimes 90 minutes or 2 hours or 3 hours doing tip blast. You can achieve your goals in 20 minutes. Please watch all my videos. I have about 300 videos on rhinoplasty, Bizrah Academy, more than 300 videos, full septal rhinoplasty, and cover all cases, the hum, the wide nose, the crooked nose, the saddening, revision rhinoplasty, all being covered, and we are doing second by second. We are not cutting any part of the operation. And then you will get the feeling that it's really a good technique, and it would worthwhile start practicing this technique.
Okay, very good. And what are the advantages of the external osteotomies, in your opinion?
First of all, I mean, when you do internal osteotomy, you have no control, and we'll be dividing the 3 elements of the bone. What I mean by the 3 elements of the bone is covered by from outside by periosteum and from inside by membrane called endosteum. So when you're doing the internal osteotomy, you are cutting these 3 compartments, so you lose the control of the bone. So the bone, the nasal bone may collapse in. But when you do the external osteotomy, you have full control and a direct vision, and we are going through the periosteum and the bone and leaving the endosteum alone. So we are not penetrating the inside membrane of the bone, exactly as when you brace on the egg. When you brace on the egg, you keep the inside membrane intact. So this will prevent and reduce the possibility of bone collapse. And as you have seen, I put 2 cases of external osteotomy, how you can get full mobilization of the nasal bone without any collapse.
Okay, and any variation on the spanning suture? I mean, the lateral crude approximation suture?
Yes, actually the spanning suture is very useful suture because it will save you doing trimming of the kyphocatarrhal cross. So when you have a patient with supraalar fullness at the end of your procedure, either unilateral or bilateral, what can you do about it? You either do the lateral crude overlay technique to, I mean, divide the convex portion or concave portion of the lateral cross, or do the spanning suture. You don't have to go and trim the kyphocatarrhal cross. If you trim the kyphocatarrhal cross, we will end with maybe collapse and asymmetry of the tip and even deviation after a few months. So because you are disturbing the balance of the alar cross in both sides. So therefore the spanning suture is very useful suture in achieving the more tip definition and refinement with preservation of the lateral cross. The variation now, if you want to keep, if you don't want to achieve any rotation and keep the patient nose in the normal position, some patients tell you, please don't do any rotation for me. In this case, you do your suture. When you go through the intercartilage incision, you go straight as the anterior septal angle. If you want to go do a rotation, you go slightly posterior to the anterior septal angle. If you go posterior to anterior septal angle, you get more rotation of the tip. And if you want to lengthen in short noses, if you want to lengthen the nose, if you suture the 2 lateral cross directly, without going through the septum at all or going through the intercardial incision, this will push the tip down. This will push the tip down and make the nose more longer. So it's very useful structure. We will have a video about this variation of the tip technique.
Excellent. And last but not least, do you think the division of the pressor septinacy must be mandatory in all cases?
Actually, it has to be done in the tension noses when you have long humpy nose with short columella and short lip, and also patients when they complain, whether when they laugh or they will smile or talk or eat, as the nose either goes down, drop down, or become wider. So in this case, it has to be done. Because, for example, if in tension noses, in droopy noses, if you don't do it, okay, the nose profile will look nice first few months after surgery, but the tip will be still under continuous tension to be pulled down every time the patient opens his mouth. That every time the patient talks, smile, laugh, eat, or drink, the tip will be under continuous tension. So therefore, it's mandatory to divide this muscle in these cases to reduce the tension on the tip.
Yes, I completely agree because I do it in all my cases as well. Okay, so thanks very much, Dr. Bizrah, and I remember to all the participants for all the questions. You can address your questions to info@rinoplastyabizrahacademy.com. Dr. Bizrah, thanks again. It was very brilliant. Thank you very much.
Please put your questions, and I'm going to answer it all tomorrow. Thank you very much. You are most welcome.
Thank you. Thank you. Thank you all.
Thank you. Bye-bye.